Hi everyone, my name is Alex Herrera and this is my presentation on how the urinary system changes in geriatric patients. So this here is just a basic anatomy of the urinary system. It consists of two kidneys that produce urine, two ureters that transport urine towards the bladder, a urinary bladder which stores the urine prior to elimination, and the urethra which conducts urine to the exterior. So this here is just a basic physiology of the urinary system. The urinary system has three major functions, which is excretion, the removal of organic waste products from body fluids, elimination, the discharge of these waste products into the environment, and homeostatic regulation of the volume and solute concentrations of the blood. So examples of this homeostatic regulation is the regulation of the blood pressure, regulating sodium and potassium concentrations, stabilization of the body's pH, conservation of nutrients, and assisting the liver with detoxification. So these are just a few basic changes in the geriatric population. So the number one thing is that the kidney size decreases. The kidney size can decrease by 20 to 30% in people aged 30 to 90 years. So this comes with decreased renal blood flow and alterations in hormone levels. So some of these hormones include aldosterone and ADH, which can, of course, cause alterations in the excretion of fluid and electrolytes. These patients also lose glomeruli function. 30 to 50% of the glomeruli lose function by age 70. The urethra and the bladder lose elasticity and muscle tone, and that can alter urinary patterns and cause incontinence and infection. In females, estrogen deficiency causes dry, thin vaginal tissue, and in males, they can experience prostate enlargement, which can lead to hesitancy, frequency, and urgency with urination. It should also be noted that even though these changes might seem fairly drastic, older adults can still maintain regulation in their urinary system unless they're met with an unexpected disease or any kind of physiologic stressors. So this is just a basic assessment that a nurse might notice when looking at some of these patients. Because the kidneys decrease in size, they're going to become less palpable. If you're looking at diagnostic tests, the bun and serum creatinine levels will increase because of less glomeruli filtering the blood. You might notice an alteration in drug excretion because the kidneys can play a big role in excreting drugs. You might notice that their bladder is still palpable after they urinate because they can tend to retain urine. You might also notice that the patients report stress and overflow incontinence, and they may also report frequency of urination, urgency to urinate, and nocturia, which is when they have to get up in the middle of the night to go and use the restroom. So now I'm going to outline three different conditions that these patients may experience. So the first one is urinary incontinence. This is very common in older adults, but it's important to note that this is often stigmatized, underreported, underdiagnosed, and undertreated. Older adults may convince themselves that this is normal, or they may feel embarrassed to report it. This is not normal and it can be treated. And we're going to get into that later on in the presentation. Urinary incontinence is caused by loss of bladder control. And there are 5 different types of incontinence, and I left a nice little visual aid for y'all as a method of assistance to help remember which type of incontinence is which. So we have stress incontinence. This is the loss of a small amount of urine with activities that increase intra-abdominal pressure. And that includes coughing, sneezing, or even exercising. And then there's urge incontinence, which is the loss of moderate to a large amount of urine before getting to the toilet. So it's basically the inability to suppress the need to urinate. And then there's overflow incontinence, and this is when these adults have a nearly constant flow of urine loss. So basically what we would call dribbling. They can experience a hesitancy in starting to urinate. They can have a slow stream, and they can also have a feeling of incomplete bladder emptying. And then we have functional incontinence. This is when the urinary tract is intact, but these patients are unable to reach the toilet due to environmental barriers. Like maybe they're not able to get to the toilet on time. They may have physical limitations. They may have cognitive impairment or even lack of assistance. And then we have mixed incontinence, which is a combination of more than one urinary incontinence problem, and it's typically stress and urge incontinence combined. So next up we have urinary tract infections. This is the most common cause of bacterial sepsis in older adults. Organisms that usually cause UTIs are introduced through the ascending route from the urethra and originate in the perineum. E. coli is the most common pathogen that can cause a UTI, though there are multiple organisms that can also cause UTIs. Common risk factors include urologic instrumentation, such as the famous catheterization, and sexual intercourse. So for older adults who are sexually active, intercourse promotes milking of bacteria from the vagina and the perineum. Just a little explanation there. Some people can be asymptomatic, but others can experience a wide variety of symptoms, such as dysuria or pain upon urination, frequent urination, so more than every 2 hours, urgency, and suprapubic discomfort or pressure. The patient's urine may contain grossly visible blood or sediment, which is what gives the urine that cloudy appearance. Other common symptoms are flank pain, chills, and fever, and this can easily be treated with antibiotics. So the third condition that I have here is chronic kidney disease, which is the progressive irreversible loss of kidney function. CKD has multiple causes, but the most common causes are diabetes or diabetic nephropathy and hypertension. Other risk factors include being over 60 years of age, cardiovascular disease, family history of CKD, and exposure to nephrotoxic drugs. The course of CKD is highly variable depending on the cause as well as the patient's age and health condition. So some people can still live very normal and active lives with CKD, but others may progress very rapidly and be at the end stage much quicker. All body systems become affected with CKD, and it's because what is normally being excreted is now being retained in the body. So this is hormones, urea, creatinine, fluids, and electrolytes. This can cause hypertension, it can cause heart failure or metabolic issues, anemia, CNS depression, and many more symptoms. Okay, so here I have a few educational tips for these geriatric patients. To help with urinary incontinence, it's important to schedule voiding. This helps patients with treating urge and functional urinary incontinence. This can also help to prevent UTIs because patients will be emptying the bladder regularly. It's also important to be doing Kegel exercises. Kegel exercises involve repeating voluntary pelvic floor muscle contraction with the goal of strengthening the muscle and decreasing incontinence episodes. For patients who may be at risk for CKD, it's important for patients with diabetes and hypertension to go in for regular urinalysis because early detection and treatment are the primary methods for reducing CKD. It's important to also monitor these patients' blood pressure to detect elevations so that treatment can be started early. And it's also important to ensure proper diagnosis and treatment of these patients' diabetes since it is the leading cause of CKD. In order to prevent UTIs, when females void, they should be taught to wipe themselves from front to back to prevent the spread of bacteria. And it's also important that they're flushing out their systems by drinking an adequate amount of fluids every day. And a good way to measure adequate fluid intake is by taking a person's weight in pounds and dividing it by half. The quotient is the number of ounces that a patient should drink in 24 hours. And that concludes my presentation. Thank you.